Hi, good morning. My name is Tim Morris. I'm a professor of medicine in the Pulmonary and Critical Care Division at the University of California, San Diego, and I'm here representing the Respiratory Compromise Institute. The Respiratory Compromise Institute is focused on the proper care and treatment of people who are not quite in respiratory failure, but not stable either, and hence the phrase respiratory compromise, meaning that they're at major risk for developing life-threatening respiratory failure. We recognize at the Institute that respiratory compromise can come in a variety of different conditions, such as an impaired ability to control breathing itself, impaired control of the airways, parenchymal lung disease, increased airway resistance, hydrostatic pulmonary edema, and then pulmonary vascular disease, which has its own set of pathologies that can put people at risk. We're very interested in marshaling a variety of resources to try to fight the problems due to respiratory compromise, and have organized a group of representatives from various different organizations having to do with respiratory health. Today, though, we have a special guest speaker, Dr. Eddy Gutierrez, who is a critical care specialist. He is at Baptist Medical Center in Jacksonville and Baptist Clay Medical Campus. Dr. Gutierrez received his Doctor of Medicine from the University of Costa Rica in 2011. He did his residency at the Memorial University Medical Center in Savannah, Georgia in 2015, and finished his fellowship at Wake Forest University Baptist Medical Center in 2017. Dr. Gutierrez also has a podcast called the Saving Lives Podcast, and I do recommend you take a listen to it. It's quite interesting. But today, Dr. Gutierrez is going to be speaking with us about the proper care of patients with respiratory compromise using high-flow oxygen. Dr. Gutierrez, it's great to have you here.
First of all, I'd like to thank the Respiratory Compromise Institute as well as Dr. Tim Morris for having me here today. My name is Eddy Gutierrez. I'm an intensivist and thrilled to be joining you all to speak about the utilization of nasal high flow in patients who have unexpected respiratory compromise. Something I like to say about every time I go ahead and I lecture is that I try to use as much evidence-based medicine as possible, and I like to make it accessible for people to see where I obtain these data from. And amongst that, on my actual slides at the bottom, I have the actual PubMed ID of every article that I cite and where I get this information from, because I like for people to be able to see where I got this from and actually check the data out for themselves. So I'm going to be discussing about the utilization of nasal high flow, also called high flow nasal cannula. I mean, it has a whole bunch of different initials in the literature. But one of the things that's very crucial for us all to know is the actual mechanism of action of the device. And many of us already have this device at our respective institutions with different setups or whatnot. But the bottom line is that they have several components, including a flow meter. And some devices go up to 60 liters per minute. And one of the reasons why this flow is actually important, as you just see how the normal respiratory drive actually takes place, is that, we tend to pull up to 35 liters of flow with 35 liters with every breath that we take. And if you just go ahead and put somebody on, for example, 4 liters nasal cannula, you don't get that 100% FiO2 that you desire from the actual device itself. It's obviously not its intended role. But when you do give these patients the amount of flow that they request, the amount of flow that they're trying to take in, and let's say you put them at 100% FiO2 and you give them that actual FiO2, well, that's what the patient is actually going to end up seeing. So with these devices, you could actually, utilizing the air oxygen blender, actually titrate the exact FiO2 more precisely that these patients are going to be receiving when they are on nasal high flow. Then in addition to that, there's other benefits such as the active humidifier, which keeps our cilia happy, lets us go ahead and expectorate things. And the heated circuit is actually good for comfort as well. Also helps avoid bronchoconstriction in patients. And then last but definitely not least, on this interface, you do have the actual nasal cannula itself, which allows patients to go ahead and speak, eat, interact with us. We can talk to them while we're trying to get an H&P or do a consult note on these patients. But all these things together help to increase the airway pressure of the patients, and they help increase the end expiratory lung volume, which helps recruit lungs in these patients and also improve the lung compliance of them. This ultimately helps out with the oxygenation of the patient, and cranking up the FiO2 also helps there as well. And these things, this improvement in the lung compliance helps decrease the respiratory drive of our patients and just decreases their respiratory rate. It also washes out dead space, and I'm going to get into a little bit more of the nitty gritty of that component of all that a little bit later, but it does help decrease CO2 clearance, helps decrease the work of breathing of these patients as well as their respiratory effort. With the active humidity, it just makes it so much more comfortable for the patients. And there are different mechanisms, and you go ahead and take a screenshot of this if you'd like, because I'm not going to go over this because it's going to, bore you. But there are all these different components help to make the device more comfortable, helps improve oxygenation, overall improve clinical outcomes in our patients. Now, one of the things that's most controversial that I hear a lot of discussions about is whether nasal high flow actually generates PEEP. And this is always very, very entertaining to me because, by definition, PEEP needs to be a closed circuit. But, we've kind of made estimations using different clinical trials and different models where they have actually found using 30 to 50 liters of flow generates between 3 to 5 centimeters of water of PEEP. And they've actually created devices where they've been able to crank up greater than 10, almost 100 liters of flow. And they found that for every increase of flow by 10 liters, you get about 1.16 centimeter of water of pressure. And then most recently, this is very up-to-date information, where in February 2023, they actually created a systematic review and meta-analysis looking at different flow rates on patients using different devices and whatnot. And they've actually found that the more you crank up the flow rate, the more airway pressure you end up generating in these patients. But the key question is, what about mouth breathers? Kind of like Joey right here, you're going to expect a decreased efficacy of the actual device in patients who are mouth breathing. And that is what's being seen in the data. Back in 2011, these data were published that, it shows that with the mouth closed, you do have this increase in airway pressure, but although you do see some increase in airway pressure, it's definitely not the same when you have the mouth opened. And again, more recently, and I know that you can't read this slide, but it just shows you all the different devices and all different pressures that they used to basically delineate the difference between the blue lines, which show the mouth being closed, versus red being the mouth being opened. So just keep that in mind. But we have to remember that the whole thing about nasal high flow is the bread and butter being acute hypoxemic respiratory failure. And I'm not going to get too much into this case presentation, but you could kind of figure out what the diagnosis is, given that this is somebody who I took care of in January of 2020. And this patient showed up to the ED with a viral illness, which shall not be named. And the ED doctor called me very concerned because this was a chest x-ray upon presentation of the patient. And so the whole thing is the ER doctor wanted to go ahead and intubate this patient. But I said, let's give her a go on nasal high flow and see how she does. And this is on the 13th of January. Just kept her on high flow. This is on the 22nd of January. In other words, 9 days had already passed, and she still has these manifestations on her chest x-ray, which, are very concerning. And we've all seen this ourselves. But I just continued her on nasal high flow. She was eating, walking around her room, et cetera, et cetera. And even on the 31st of January, over 2 weeks after her presentation, her chest x-ray was starting to improve. But if you notice some things that are missing, she has no tracheostomy tube, there's no PEG tube, there's no central line in place, which if the patient had been intubated by that point, well, chances are she would have bought herself a couple of those procedures. Even over a month later, she still had those bilateral infiltrates, but again, she was not requiring any procedures or any interventions, and she ended up going home. However, if she would have been intubated at some point, well, then chances are she would have ended up in an LTAC or a nursing home, which, they do good work there from a patient care standpoint. However, it's not the same as going home, which she ultimately did. But what gave me the clinical basis to actually do that was the Florali trial that was published in 2015 in the New England Journal of Medicine, where they randomized patients with acute hypoxemic respiratory failure to either have non-invasive conventional oxygen therapy or nasal high flow to see how basically they did. And the primary outcome was intubation rates at 28 days, but there was no difference here. So I know what you're thinking. Hey, Eddie, why are you sharing these data with us if there's no difference in the outcomes of these patients? But what they found is that in the sicker patients, the patients who have PF ratios less than 200, there was a superiority that was found in the patients on nasal high flow. They also found that these patients had decreased ICU mortality, decreased 90-day mortality, and overall they had more ventilator-free days using the high-flow nasal cannula as opposed to conventional oxygen therapy as well as non-invasive ventilation. And here is the Kaplan-Meier curve basically showing how the nasal high flow was superior to both non-invasive as well as standard oxygen therapy. Now, one of the things to consider about the patients enrolled in this trial and non-invasive ventilation is that they actually let these patients take tidal volumes that were ACCs per kilogram of ideal body weight and up, which is definitely not something that we've all been trained to take care of ARDS management. However, we have to be very cognizant when we care for these patients with ARDS type pictures that they're not taking these monster tidal volumes when they actually breathe, because you're actually causing them polytrauma and barotrauma. So this has led the various societies to go ahead and state that there's a strong recommendation in patients with acute hypoxemic respiratory failure to go ahead and use the nasal high flow. In fact, even the surviving sepsis guidelines most recently now in 2021 state that, hey, they suggest using nasal high flow over non-invasive ventilation, even though it is a weak recommendation with low quality of evidence. And the European Respiratory Society also suggests using nasal high flow over non-invasive ventilation in patients with acute hypoxemic respiratory failure. So it seems to be our go-to for right now. In fact, they're even trying to make modifications, which is beyond the scope of this particular talk, to the Berlin criteria to include utilizing nasal high flow as one of the characteristics of the definition of the Berlin criteria. But what about COVID patients, though, right? Because as much as I'm burnt out on COVID, just like everybody possibly listening to this webinar is burnt out on COVID, this is something that we just need to be prepared for in case it happens again. And in reality, that they found in this randomized control trial that was published in September of 2022 that there was no difference in mortality utilizing nasal high flow compared to conventional oxygen therapy, which is kind of disappointing because, we got to find every advantage we can for these patients. However, at the same time, they found that there was a decreased incidence of intubation in these patients with a number needed to treat of 12.5 when they used nasal high flow over conventional oxygen therapy. But one of the things that we could also consider doing to give our patients an advantage is to go ahead and prone them on nasal high flow. And the data for this actually goes back to 2013 when they used healthy specimens, which were probably med students if we're being honest, and they had them supine and prone and utilizing this technology called electrical impedance tomography. They looked at the end expiratory lung volume, and if you look over on the left, it's a more heterogeneous distribution compared to the right, which is more homogeneous, and the right are the patients who are on the nasal high flow. And then we've been seeing this utilization of proning these patients come up before in other etiologies, but we really kicked it into high gear when it came to COVID. But even the data from before that shows that it helps oxygenation when you prone these patients, but ultimately there was no clear intubation benefit. But they did notice a mortality benefit when the patients were prone for 4 hours or more per day. Looking at the subset of COVID patients, here they found that there was a decreased risk of intubation in a very recent, from June of 2022, systematic review and meta-analysis, a decreased risk of intubation. But here also they found no mortality benefit. But those are just some things to consider. Now, one of the things that I found very interesting when I was just reading everything under the sun to better take care of my COVID patients is, what if your patient cannot tolerate proning? There are a number of reasons which we all likely experience that patients would not prone themselves, and instead you could try this particular maneuver, which is called the rodent's thinker. Now, I haven't particularly found any additional data looking at this, but from a empiric standpoint, I did see certain patients' oxygenation improve when they took this position as opposed to just being sitting down on the bed. Now, I'm not going to tell you how to get this through risk management and through all the administrative loopholes, because, you don't want patients falling, but definitely make sure you clear this appropriately before you start attempting it. Other indications that you could potentially use nasal high flow include patients who have heart failure, simply because of this increase in the airway pressures, this recruitment of the lungs, etc. They have found in various studies where patients who have CHF exacerbations end up having a decrease in their respiratory rate if they have nasal high flow placed. In fact, even certain European cardiology societies have high flow nasal cannula in their algorithm to manage patients with acute hypoxemic respiratory failure from heart failure. And, they want to avoid intubating the patients or whatnot. Obviously, it's not going to work on everybody, but it's a tool that we have in our back pocket to potentially help out our patients and also have them be a little bit more comfortable. Now, a study that was recently published in December of 2021, which I thought was pretty interesting, was this particular randomized control trial where they enrolled almost 200 patients to either have this helmet device, which we don't have available in the United States, at least to my last knowledge, versus the nasal high flow in patients with cardiogenic pulmonary edema. And as one would expect, at least those of us who have been familiarized with the functions of the helmet devices, well, the helmet did help these patients more so than the nasal high flow, even at 50 liters. But there were some interesting findings that I'd like to share with you and why I brought this up to light. And it had to be with how much these patients improved from their baseline to being transitioned over to the nasal high flow. And amongst these improvements include a decrease in their respiratory rate, their mean arterial pressure improved, their heart rate improved, their oxygenation improved, their PF ratio improved, as well as their dyspnea. So even though this device, the nasal high flow, was definitely not superior to using that helmet device, which obviously could provide these patients with more pressure, the patients still did have an improvement from baseline. And, that was just something interesting I found and I wanted to share with you all today. What settings do they recommend starting patients with heart failure exacerbations? Well, start with an FiO2 of 100%, start them on 50 liters of flow, and then you go ahead and you titrate up as needed for your patient. Every patient is an individual, and we need to titrate all their medications and therapies based on their particular needs. So let's stretch out a little bit and talk about the utilization of high-flow nasal cannula and COPD, because now we're stretching, right? But from a principle standpoint, we know that this does create some washout of the CO2 that's in the upper airways and such. And this particular schematic, you see how on 15, 30, and 45 liters, the more flow you provide the patients, the more there is a washout of this reagent that they were using to, show this model. And even utilizing actual humans in this type of MRI technology, they found that turning on the nasal high flow actually does wash out the upper airways from CO2 in patients. And the whole thought process is that this washout of the CO2 decreases the work of breathing of the patients, further decreases CO2 production, and therefore decreases the ventilation needs of our patients. There have been studies that have been performed within the last 5 years that show that there's a percentage decrease in CO2 by actually giving them even 20 liters of flow. It showed about 9% decrease in their baseline CO2, and at 30 liters of flow, it decreased it by 12.6%. So there is some data out there to support this. And looking now at that systematic review and meta-analysis just a little while ago that I shared with you, that was published just now in February of 2023, they looked at these different devices, and you see that as you go increasing the actual flow, which is on the x-axis, you do see a percentage change in the patient's CO2. So the more flow you can provide your patients, better if they keep their mouth closed, of course, you do ventilate your patient better with these devices. And they've tried to look retrospectively at patient populations with a pH of 7.25 to 7.35. I would never think that putting high flow on a patient who has a PCO2 of over 100 with a pH 6.9 will ever be efficacious to be able to get the patient out of the hole that they're in. But the sweet spot might be, at least for the time being, of 7.25 to 7.35. And retrospectively, they found in this particular study that was published in 2019 that these patients although there was no difference in treatment failure, well, again, comparing them, to non-invasive ventilation versus high flow, they found that there was no difference in treatment failure, in PaCO2, nor length of stay. What they did find is that there was less interventions by the respiratory therapists as well as the nurses because, all of us who take care of patients on non-invasive, they're trying to move the mask around, they're trying to eat around it, they're trying to talk to you, etc. And so, that's just messing around with the device. There was also less facial and skin breakdown in these patients, which, is beneficial for them. We don't want to cause any pressure ulcers and such on our patients. But they did find, curiously, that there was a longer duration of the device with the application of the nasal high flow. And it's my opinion that a confounder for that is the fact that patients, even though they are on nasal high flow, they're still more comfortable with it, and they can still eat, they can still drink, they can still communicate with their families. And so they're not bugging the nursing staff and the respiratory therapist to go ahead and have the mask removed. So that might be a confounder there. More recent randomized controlled trial of almost 80 patients. Again, small studies for right now. I mean, that's just what we have. I'll show you what's coming up in the pipeline though. Looked at nasal high flow versus non-invasive ventilation. And here again, they were using a pH of 7.25 to 7.35 with a baseline mean PaCO2 of 73. And what they were looking at was the difference in the PaCO2. And they found that in reality, there was only a small difference between the non-invasive ventilation as well as the high flow in the PaCO2 of these patients. Also interesting is that they did not find an increase in the need for invasive mechanical ventilation. So here, by testing out the patients, at least on the nasal high flow, it did not lead them to needing to be intubated. Unfortunately, 32.5% of patients still went on to need non-invasive ventilation, so it didn't work for absolutely everybody. But along the same lines, 60% of patients did just fine on the nasal high flow and did not need to wear the non-invasive mask. They have tried to do systematic reviews and meta-analyses with the current data that we have on COPD exacerbations and high-flow nasal cannula. But if I'm being quite honest, they're all very small, underpowered, not very robust. And even in these cases, they have shown no difference in intubation rates, no difference in mortality. But thankfully, there are a number of authors and researchers and clinicians out there who are currently enrolling patients and recruiting to try to see if they could tease out which ways we could use nasal high flow in patients with COPD exacerbations. Algorithms exist already for the utilization of nasal high flow in COPD exacerbations, and this is the algorithm that I've run into the most, which basically says if your patient has COPD and they need to be intubated, we'll go ahead and intubate them. No need to waste time. And obviously, if they're on nasal high flow and they're not flying, just keep it on them for pre-oxygenation, and then you just crank that bad boy up so that you can oxygenate the patient the best way possible. But if they're not needing to be intubated emergently, then you give them oxygen, you give them nebs, steroids, etc. And if the pH is less than 7.25, you just go ahead and you put them on non-invasive ventilation. You want to maximize your chances of success. But if your pH is 7.25, 7.35, that's when you start the patient on nasal high flow rate between 50 to 60 liters, and whatever FiO2 needed to hit that SAT goal of 88%. But one of the key features here is to set the temperature at 37 degrees. There's a tendency amongst respiratory therapists to just start these patients on 31 degrees for the sake of, the patient's not moaning about the actual air being too hot. They talk about utilizing the nebulizer with nasal high flow, but I'm going to go ahead and skip that. And you just keep on assessing your patient to see if they're going to fly. Obviously, if they're desatting, if their breathing patterns look awful, if they're tachypnic, etc., their acidosis is getting worse, well, you got to bail. You got to either put them on non-invasive or you have to go ahead and intubate them. So those are going to be your exit strategies. But if they're doing okay, you continue to titrate, continue to monitor your patients, etc., and you'll eventually wean it once they get better. Asthma is another place where people have considered using nasal high flow. However, these studies have been very small, not very robust at all. What they have shown is a decrease in respiratory rate. Although people are using it in clinical practice for asthma exacerbations, it's not something that's very substantially validated, so to speak, in the literature today. But one of the things that people have issues with the nasal high flow is the fact that they feel like they're flying blind. When we have patients on invasive mechanical ventilation, we can look at the screen, look at the waveforms, look at everything, and we know what's going on with the patient. Same thing with non-invasive ventilation. It reassures us to be able to watch the patient's respiratory rate. But with the nasal high flow, at this point where we stand right now in 2023, we're kind of flying blind, it feels like. And this is where the ROX index comes into play. And the ROX index is a calculation that is the SpO2 over the FiO2. You take those two and then you divide it by the respiratory rate. So when you go ahead and enter this into your calculator, because I'm not impressive enough to be able to do this in my head, you have to enter the SpO2 as a whole number. Then the FiO2 actually needs to go ahead and include the decimal. And the respiratory rate needs to be accurate on these patients. And this sometimes forces you, so to speak, to be a little bit creepy because you have to kind of watch the patient as they breathe. You can't just use that 20 that's documented all over the place, or 18, or, you choose your number. You actually have to see how fast these patients are breathing so that you maximize your chances of this actual calculation being beneficial. But there are also calculators so that, you don't have to do that on a piece of paper. There are also calculators that exist that, where you could enter these numbers and they'll calculate the ROX index for you. But the question is, how accurately does the ROX actually predict nasal high flow failure? Because people always think, oh yeah, if I just look at the respiratory rate or whatnot, or, I could tell if they're going to do well or not. Well, it turns out that we're not as good as we think we are when it comes to this. And they've looked at the diagnostic accuracy of different respiratory variables in this particular paper that was published in 2016. And they found that at 12 hours, 18 hours, and 24 hours, the area under the receiver operating curve of the ROX index compared to these other metrics which we use was superior. Now, for those people who are a little bit rusty at statistics, when you're looking at receiver operating curve, if it's basically between 0.8 and 0.9, as this was at 18 and 24 hours, it's considered to be excellent. So something to keep in mind. So which ROX index, you go ahead and you get your number, you calculate it, etc. Which ROX index actually goes ahead and predicts a decreased risk of intubation? And that number is, if the ROX index is greater than 4.88 after 12 hours, the patient has a decreased risk of needing invasive mechanical ventilation. And that number actually carries forward to 2, 6, as well as the aforementioned 12 hours. Predictors of ROX failure, however, is that if the ROX index is less than 2.85 within 2 hours, well, patient likely needs to be intubated. If it's less than 3.47 at 6 hours, that patient needs the tube. And if at 12 hours is less than 3.85, well, this patient likely needs to be intubated because the high flow is not going to cut it. But I know that these numbers right now, like that 4.88 and all that stuff, just sound pretty abstract right now. So I'm going to take a moment to go ahead and show you what it'll look like in clinical practice. So here, for example, somebody who has a ROX index of 9.5, for example, is somebody who's setting 95% on 50% of FiO2 and breathing just 20 times per minute. That patient's going to fly and do well. Now, somebody setting 95% on 90% of FiO2, which is still concerning, but has a respiratory rate of 21, well, their ROX index is also doing okay. There exist nomograms of sorts or tables such as this one, which you could screenshot right now, so you can save it and put it in your back pocket or put it on your phone. Just make sure you take my little face out of the lower right corner. And you can see how depending on the FiO2 and the respiratory rate of the patient, where the patient's safe zone is, or where you could be a little bit more comfortable with how they're doing. Now, people who aren't going to fly include this patient who has a ROX index of 2.79, who's setting 92% on 100% FiO2 but breathing 33 times per minute. That patient's not going to do well. An example of somebody who is also not going to do well, somebody who's setting 92% on 90% FiO2 but breathing 30 times a minute at 6 hours. This person's not going to fly either. There are tables such as this one, which I had it until I had the whole ROX index memorized. I had it on my phone as one of the images on my favorites, but basically says how to decide management on the patient depending on the ROX index. So this is pretty convenient. There are also algorithms that I've seen ER doctors carry around in the past where you make adjustments to the actual device itself, whether it is to increase the flow or increase the FiO2, and then just go ahead and reassess the patient. An example of that is, somebody who's kind of in the gray zone between 2.85 and 4.87 is listed there. You increase support, and then you calculate a delta ROX. And if the delta ROX is greater than 0.5, then, you continue monitoring them. But if it's less than 0.5, you should really consider intubating the patient. Is there anything else that we could do to nasal high flow to actually improve outcomes in these patients? COVID made us kind of desperate when it came to patient management and trying new things, which it's just the way it was. Some folks tried nitric oxide, and these data are from the Cleveland Clinic, where they actually had the nitric oxide system hooked up to the nasal high flow. And, they tried to keep patients off of invasive mechanical ventilation like that. Other institutions went ahead and tried EPOPROSTENOL and high flow nasal cannula to try to avoid the mechanical ventilation. Obviously, our patients did not have smiles on their faces like this young lady does in this particular image. But yeah, this was something that we tried at our institution. We actually tried both of them to see if they would improve outcomes. One other way that we could use nasal high flow, and I use it quite frequently, is in the post-extubation period. When we go ahead and try to extubate patients as soon as possible, we could obviously bring patients into two different groups, such as low risk and high risk. In this low risk study, they randomized patients to either be placed on nasal high flow or conventional oxygen therapy. And what they found is that with regards to all-cause reintubation, it was beneficial to be placed on high-flow nasal cannula over conventional oxygen therapy, with the number needed to treat to avoid one reintubation of being 13.7. But what about high-risk patients? And here they randomized patients to receive either non-invasive ventilation or the high-flow nasal cannula. But all in all, in this paper, they found that there was no difference between the two, between the non-invasive ventilation and the high-flow nasal cannula. But there was no difference in all-cause reintubation. There was no difference in post-extubation respiratory failure. But one thing that they did find is that there were more adverse effects in the patients with non-invasive ventilation, like the pressure wounds and things of that nature. So that's just something to consider, because there were no adverse effects noted in the patients who were on the high-flow nasal cannula. So it's a conditional recommendation to use the nasal high flow after extubation. Every patient is different. We all know for our patients that we're caring for, the exact etiology that made them go into respiratory failure. So we can kind of deduce which device is going to be better for them. We've also looked at using postoperative high flow nasal cannula in obese patients or patients who go through cardiac and thoracic surgery. And there's a clinical recommendation to use high flow in these patients because they do benefit to some degree from the actual airway pressures provided by the device. What they have found in this more recent systematic review and meta-analysis looking at the utilization of high-flow nasal cannula in the post-operative period is that it does decrease the risk for reintubation when they looked at over 2,000 patients who were at risk for reintubation. It also decreased the risk of escalation of care, so another benefit here. One of the topics where I was hoping that nasal high flow would be more beneficial would be in the peri-intubation period, where you basically have the nasal high flow on the patient, and then you go ahead and secure the airway, and then you take it off after the endotracheal tube is in place. But the data hasn't really shown any benefits here. So what I do in clinical practice is that if my patient's on nasal high flow, I just leave it on them and I go ahead and intubate them in that fashion. If they have the non-invasive ventilation on their face, well, then I pre-oxygenate them with that. Or if they have a non-rebreather, I just leave that and I intubate them like that. But I don't go ahead and start switching devices just for the airway. Different academic centers, or depending on who does the intubations at your institution, you might consider a different practice. But, for the sake of evidence-based medicine and trials, it hasn't shown any differences. So also no differences in peri-intubation complications. So there's no recommendation to actually use nasal high flow in these patients, just to put them on them, just to go ahead and intubate them. Now, last but not least, it can't all be like just easy stuff. There have to be some complications, correct? And this is where the complications that have been listed have been, kind of insignificant, to be honest with you, because What has been reported is just patients feeling hot from the actual temperature or some thoracic or cervical discomfort. And then some people have complained about unpleasant smell or the temperature being too warm or having some sort of chest discomfort. So these are all different things that have been seen in the utilization of nasal high flow. And definitely think it's a cool technology. It's worth exploring if you haven't been doing so yet. It's been something that I've been actually working with since about 2014, 2013 or so. So I have a good amount of experience with it. I've enjoyed working with it, and definitely have to thank everybody for watching this webinar, and definitely going to be open to any questions, comments, complaints, concerns. And thank you all for tuning in and for listening to me go off about this for a little while.
Well, thank you, Dr. Gutierrez, for a great presentation. We got a few questions from the webinar. So the first question is, are there specific surgical procedures that may lead to respiratory compromise?
Well, this is a good question because there are so many different surgical procedures that are done. You know, I have quite a bit of experience in surgical ICU as well as cardiothoracic ICU, which is what I do a lot of today. And when it comes to patients who are in the cardiothoracic ICU, for example, there is good evidence for the utilization of high flow, for example, in patients who need to be extubated within those 6 hours, those magical 6 hours, or even the 24 hours after cardiac surgery. But those patients who might need a little bit better oxygenation, might need some increased airway pressures, that PEEP-like effect that I just mentioned before, that might be seen in a lot of patients who are, for example, suffering from obesity and things of that nature. Then there's also data on patients who undergo bariatric surgeries. And well, you just got to think about these patients who are a little bit on the heavier set side, and they tend to, have history of obstructive sleep apnea, for example, and they just might need a little bit of positive pressure. And the high flow nasal cannula system could go ahead and provide that for the patients to avoid them escalating to either needing non-invasive ventilation or needing to be intubated, which is what we really, really try hard to avoid to do with these patients.
Next question, are there hospitals allowing a patient to be on humidified high flow beyond the ICU or transitional care areas?
Unfortunately, during the recent pandemic, we've all had to kind of go a little bit beyond our comfort zones. I know of many institutions that used to only have the high flow systems in their intensive care units, but that went ahead and got trickled down to the PCU units or IMC or whatever you call your step down unit at your respective institution. But this actually led the pandemic, unfortunately, led the high flow systems to be utilized in sometimes some med-surg tele floors, which, is beyond the scope of comfort for a lot of nursing staff as well as respiratory therapists. But, with this need came the ingenuity to be able to do it, and people stepped up their game and definitely got trained for it. But nonetheless, these systems are used quite frequently outside of the ICU, like I said, in the step-down units, but also I see it quite frequently in the emergency department where, patients with unexpected or unexplained acute hypoxemic respiratory failure and, just a regular nasal cannula is not cutting it. They just get the high-flow system placed on them until they're able to find out the etiology and transition the patient over. But in addition to that, PACUs are using it. And it's just something that is being used more and more throughout the different hospital systems.
Okay, next question. What are some comorbidities or medical history items that I should be more alert to as it relates to potential respiratory compromise?
So this is kind of a big question because when we interview our patients, we definitely take a good medical history and, patients with recurrent pneumonias, for example, history of aspiration, those patients who have had like a CVA with recurrent aspiration pneumonias, etc., they will likely benefit from being on the high flow nasal cannula system during the course of their pneumonia. But actually COVID, as I mentioned before, a lot of people ended up using it for that. From a past medical history, comorbidity type of thing, I always get cautious, or my alarm goes off, so to speak, with the patients who have obstructive sleep apnea and obesity hypoventilation syndrome. And the reason for that is because we could try really hard to go ahead and put their home CPAP on them or put non-invasive on them while they sleep. But the reality is a lot of these patients, since they're ill, they just fall asleep at all times. And this is just something that becomes quite tedious for the personnel to have to go and run and put the non-invasive on them and then this, that, the other. But if you just have them on the heated high flow and then have them with some positive pressure being delivered to the patient, then they might fall asleep and they won't become hypercapnic in the interval. So that's just something I try to keep in mind. I really can't think of anything off the top of my head, but we just have to be aware of that. People could be resuscitated for their septic shock. And, even though we're giving patients a lot less fluid these days and not putting that many patients into pulmonary edema, it's still something that's taking place. And, for this increased work of breathing or whatnot, this is something where the Surviving Sepsis Guidelines is actually recommending the utilization of the high flow nasal cannula over non-invasive ventilation. But again, that's a different population.
Another question is COPD a contraindication for the use of humidified high flow?
Absolutely not. COPD is not a contraindication for this. As a matter of fact, I showed a substantial amount of data, even though it's not robust, high quality. It's not a randomized controlled trial of 800 patients. That's all on the back burner, or not in the back burner, but that's something that's going to be mentioned or studied soon. But we do have good data to support the utilization of high flow nasal cannula in patients with COPD, especially those with a pH between 7.25 to 7.35. This is something that I do routinely in my practice and something that you could consider doing as well.
Now the question, should we turn the temperature of the humidified high flow down for these types of patients?
Again, in the COPD patient population with COPD exacerbations, the temperature of up to 37 degrees Celsius that we provide these patients is actually helpful to them. It's not deleterious at all. You should not consider turning it down. Sure, there are going to be a minority of patients who do not tolerate that temperature, and therefore you may have to bring it down a little bit. But for the most part, try to keep these patients at 37 degrees Celsius. The reason for this is we have to remember that this warm air actually bronchodilates these patients who need it so badly. So putting them on oxygen that's cold oxygen is just going to cause bronchoconstriction, and they're not going to have a good time. Again, these patients are struggling to breathe. We want to do whatever we can to get rid of that obstruction and help them get over their COPD exacerbation.
Okay, and then final question, what are some benefits of humidified high flow if a patient is requiring a small amount of oxygen?
We have to keep in mind that using high flow is not just for patients who have this hypoxia where they need 100% FiO2 to be delivered to these patients. It's a good question because a lot of folks don't quite understand, and it's tough to explain that airway pressure that I explained earlier in the presentation. But some patients just need a little bit of alveolar recruitment for atelectasis, for other issues where the FiO2 doesn't need to be so high, but what they do need is some of that positive pressure to recruit those alveoli. And again, I just alluded to the patients with underlying morbid obesity or bariatric surgeries, for example, where they just need a little bit of airway pressure, not necessarily FiO2, but a little bit of airway pressure to help these patients ventilate a little bit better. And yeah, the first times that you go ahead and speak with your RT colleagues and say, hey, I want this patient on 30% FiO2, for example, but let's try them on high flow on 50 liters or 60 liters of flow just because I need a little bit of that positive pressure. Sometimes it takes a little bit of explaining of the mechanism of action of the device in order to convince them that, hey, this is something that makes sense and this is something that could be beneficial to the patients. Now, I know that we have a lot more questions that are showing up, but we don't have enough time to get to them. But if you leave your comments down below, we will provide show notes of sorts to allow these questions to be answered, and we should have these up for you in about 2 weeks or so. So thanks so much for tuning in to our conference. I definitely appreciate your attention, and hopefully you all learned something here today. And definitely thank you to Dr. Morris and the RCI team for having me on this particular webinar, as it's been a lot of fun for me, and hopefully it's been something that has been beneficial or will be beneficial to you, your practice, and most of all your patients, because that's who we're here to take care of. Thanks so much.
Again, thank you very much, Dr. Gutierrez. It's been a pleasure.